South Europe, and Northern Europe. So you can see the incidence, which is so very high. And I think the males do tend to have a higher incidence than as compared to females. And as you go down, you can see South Central Asia and Eastern Africa, Western Africa. So it seems that the disease is occurring more commonly in the affluent societies than as compared to the developing nations or relatively less developed countries. So this is, I think, the epidemiology world over, and I think the males predominant as compared to females. Next, please. So, although the incidence is low, but pancreatic cancer is ranked as the seventh leading cause of cancer death worldwide for both the sexes. The first being lung, colorectum, stomach, liver, breast, esophagus, and you can see pancreas, which exceeds prostate, cervical, and leukemia. So, it still is a huge unmet need, as we all understand at this point in time, and this is the seventh leading cause of cancer mortality. Next. So these are the figures which talk about the survival, and you see here in UK and US, 1 year survival is 20% and 35% respectively. When you go to 5 years and 10 years, the survival is really very, 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 very poor. Even get diagnosed in early stages, the relapse rates are still very, very high in spite of improvement in the adjuvant therapy. So it really remains a very lethal malignancy. And I think in the world, there was a slide I think which is missing. There are around 4,50,000 new cases every year for pancreatic cancer. And I think the India would be having around 25,000 new cases every year. Next, please. So this is pancreatic cancer is still one of the lowest survival rates, lying at the bottom here, as you can see, and there is no real improvement since 1971 to 2010 or 11. So you see, 2.3% is the 5 year survival, 3.3%. So it's really lying at the bottom, and it's a worst kind of a diagnosis, even when patients are diagnosed with an early stage who are suitable for Whipple's. And as I said, the relapse rates remain very high. Next, please. So, like all molecular, developments happening in most of the malignancies, so we are seeing some new thoughts which are now becoming practical these days, because you have the understanding of the DNA repair genes or DNA damage genes, which are found to be mutated in patients with pancreatic cancer. And as you can see here, the mutation types in 616 patients, highly actionable, including DDR mutations, are like 2.9%, and BRCA1-2 is 4.5%, and ATM. So the total pool for the highly actionable mutations is 27%. So 23% would have other pathways where we perhaps may not have a drug at the moment. For example, WNT, AKT, MET, etc. But 50% we don't have the actionable mutations at this point in time. And when you come to the DDR mutations in the pancreatic cancer, so you can see the distribution: BRCA2 3.3%, BRCA1 1.4%, so around 5%. So which is what we are going to be focusing on today. But then there are other genes like ATM and ARDID 1A 5.5%. So so we are kind of discovering these DDR mutations in patients with pancreatic tumors, and that's what we wish to, I guess, focus on today, because we have these PARP inhibitors which are looking at these patients who are found to be having these BRCA1 and BRCA mutations. So I think with this background, we can move on to the next talk, which is I think I have the agenda. So this is by Dr. Shivinder Singh, and he is going to be talking on surgical management of pancreatic cancer. So over to Dr. Shivinder Singh, please.
I'm sorry to interrupt Dr. Sham. He's not there right now. So next talk is Dr. Bhavna Sirois. So you can.
So please, I think you can.
I'll continue. Over. No problem, sir. So, thank you so much, sir, for setting up the context, and we look forward for the further sessions. So today we have Dr. Bhavna Siroi. She's a Director of Medical Oncology in Max Super Specialty Hospital. She'll be taking us through overview of metastatic pancreatic cancer management before PAR. So over to you, Dr. Bhavna.
Thank you, Shilpa. Could you please start my video? I'm not able to. I'll just start sharing my
yes. Screen. Yeah, Yogesh, if you could help these participants to enable their video, even still it's showing disabled video for the participants.
So shall I start?
Ma'am, you can start. They will fix it. I'm so sorry.
Can you see my slides? It's okay.
Yes.
Can you see my slides? Okay.
Yes, ma'am. Your slide is visible.
Thank you, Shilpa. Thank you, Dr. Shyam. Thank you for inviting me to this talk. I'm going to talk about metastatic pancreatic cancer before PARP inhibitors. And I think Manish will take over the PARP inhibitors that have actually really made a difference for our patients. 60% of our patients present with metastatic disease. And just wanted to show a few slides quickly to make a point that performance status in advanced pancreatic cancer, as it is in most solid tumors, is very important. And as you can see from this meta-analysis, that patients who do have a good performance status do benefit significantly from combination therapy compared to those who have a poorer performance status who would not actually benefit. This study set gemcitabine as the main drug for patients with advanced pancreatic cancer and showed that the median survival was significantly better compared to a fluoropyrimidine, about 6 months versus 4.5 months, and the clinical benefit was almost 6 times more with gemcitabine than 5-FU. If you look at the various trials with gemcitabine and cytotoxic drugs, none of these studies have actually shown a significant improvement over gemcitabine alone. But if you look at the platinum compounds, so the earlier study was smaller, probably not powered to look at it, but this study with the same group, Louet et al., larger number of patients, does show that there is towards significance improvement with the addition of platinum. And I think, as Dr. Sham said, the platinums are probably going to come earlier on in treatment, especially for those 5% of patients who do have a BRCA mutation. One of the first patients with PARP-CR I had was the patient who had neoadjuvant gem cisplatin. Looking at targeted treatment, all of the phase 3 trials, none of these targeted drugs have actually made a difference, except erlotinib, which improved the overall survival for patients with a few weeks. If you look at the meta-analysis of gemcitabine combinations in advanced pancreatic cancer, the combination with platinum and a fluoropyrimidine, and we've seen with the GEM-CAPE data as per the SPAC trials in adjuvant setting, has made a bigger difference, but not with gemcitabine versus other agents like pemetrexed, irinotecan, or exatecan, which have not actually found their way into our clinics. Coming on to the 2 pivotal trials which have actually made a difference for our patients. This study randomized patients to gemcitabine, which was the standard of care, versus FOLFIRINOX, with the primary endpoint being overall survival. And we very rarely see these kind of hazard ratios in patients with pancreatic cancer. So the patients who received FOLFIRINOX had a significantly longer, almost a year median overall survival compared to those who did not. The Progression-free survival was also double with FOLFIRINOX compared to gemcitabine alone. The impact study was the second study, which again, this included patients with PS2 as well. The FOLFIRINOX study had patients with PS0 and 1. This also randomized patients to gemcitabine, which is standard of care, versus gemcitabine nab-paclitaxel. And good to see that the primary endpoint was overall survival here as well. And again, this regimen has shown a significant prolongation of overall survival, 7 months versus almost 8.5 months with the doublet. Sadly, the gem-nab-paclitaxel in the adjuvant setting was a negative trial, though the FOLFIRINOX trial in adjuvant setting was positive. If we look at both the regimens, and this is a cross-trial comparison, the progression-free survival slightly longer with 6.4 months with FOLFIRINOX, but again, one has to remember that this was a different group of patients who had a better performance status. So 1 year survival of 35 to 48%. FOLFIRINOX febrile neutropenia was significantly higher. A more number of patients need growth factors, and we know that with FOLFIRINOX, all of us use growth factors routinely now. Fatigue was significantly more. Vomiting and diarrhea was also significantly more with FOLFIRINOX. Though neuropathy was more with nab-paclitaxel. The phase 2 study, this is again another first-line study with an endpoint being a 6-month progression-free survival rate, looked at 6 months of FOLFIRINOX versus, we know that most of our patients do not actually go on to FOLFIRINOX 12 cycles. Quite a few of them would stop because of neuropathy and move on to FOLFIRI alone. So the second arm was FOLFIRINOX 8 cycles, and this was followed by 5-FU leucovorin maintenance, and the patients were re-challenged at the time of progression with FOLFIRINOX. And the third arm was FOLFIRI gemcitabine, 2 months of sequential FOLFIRI followed by gemcitabine until progression. And as you can see, the FOLFIRINOX 6 months, similar results. 6-month PFS rate was about 47%. And 44%, so very similar with in both the arms, not major difference. But the FOLFIRI followed by gemcitabine was less active. I think this study is moving forward into the phase 3 domain. The only issue with FOLFIRINOX that we have from various studies is the toxicity. And with modified FOLFIRINOX, I think all of us are not giving bolus, and this study actually shows that with irinotecan reduced from 180 to 150 per meter square, no bolus. 18 patients got the classical dose and 32 patients got the reduced dose, and the curves are literally on top of each other. So it is safe to use modified FOLFIRINOX. And there are quite a few other retrospective studies as well which have shown the same thing. So moving on to second line treatment, again, sequencing with the patients depends upon the performance status, which is the most important factor. 50%, from various studies, we've seen that about 40 to 50% patients will actually be eligible for second line treatment. And the other variables which it depends upon. Pre-existing neuropathy, I find, is very important. Risk of stent complications, convenience, choice, and some predictive biomarkers in second line setting, which I will not discuss today, but hopefully Manish will take it up. So until recently, there has been no established standard of care for patients who had progressed on first line treatment. FOLFOX type regimens, there are mixed results. If you see these 2 randomized trials, CONCO 3 and Pancreatic. In CONCO study, patients who got the doublet oxaliplatin did significantly better, but it was just the opposite in the Pancreatic study, where patients who got 5-FU leucovorin did significantly better. So sorry, I'll just come back to this slide actually. This was supposed to be after this. So this study, basically a small number, shows that patients who received nab-paclitaxel gemcitabine after FOLFIRINOX, the disease control rate was almost 60%, with an overall survival, the second overall survival of 9 months. So I think most of our patients who are fit actually do receive second line gem nab-paclitaxel if they progressed on FOLFIRINOX. So I think I've removed one slide. There was a meta-analysis which showed that patients who do receive irinotecan-based regimens do significantly better compared to oxaliplatin-based regimens in second-line setting. Nano-liposomal irinotecan is not available in India, but can be imported. I'll just very briefly discuss this. This study, patients who progressed on first-line treatment were randomized to Naliri versus 5-FU leucovorin versus Naliri plus 5-FU leucovorin. And basically, this showed that patients who received the combination regimen did significantly better with a survival of 6 months versus 4 months compared to those who got 5-FU leucovorin alone. Yeah, this is the meta-analysis I was talking about, that patients who got fluoropyrimidine alone patients who got a doublet did significantly better. So, and patients who got the fluoropyrimidine and irinotecan, I think that the bottomest plot versus fluoropyrimidine alone. So, basically, this is showing that irinotecan along with fluoropyrimidine, the patients probably fared slightly better. But this is a meta-analysis with heterogeneous group of patients, and retrospective studies are also included in this. So I think to conclude, planned sequential treatment, if patients start on gem nab-pacli, very few of our patients will actually receive FOLFIRINOX. But if they do receive FOLFIRINOX, majority of them would receive gem nab-paclitaxel, and the median overall survival is up about 18 months. And the other way around, it's about 14.5 months. So there's the Indian data, which we published when I was in Tata, and then Dr. Ramaswamy has published it as well, and on a larger number of patients with various regimens. And this is only to highlight the fact that performance status was the only significant predictor for patients who had a better overall survival, along with the oligometastatic disease. So I think to conclude, germline and somatic testing, as Dr. Shyam has said, is recommended in all patients with pancreatic cancer, including early pancreatic cancer. Gem and nab-paclitaxel and FOLFIRINOX have become the standard of care. And Manish will talk about how we fit in olaparib and other PARP inhibitors into the matrix. Genomics review board, I think, for pancreatic cancer is very important, especially when a patient has progressed and is on second line, because we still don't know what exactly is the optimal second line treatment for our patients. Thank you.
Thank you so much, ma'am, for going us for the brief overview of metastatic pancreatic cancer. So moving on to our next talk, we have Dr. Manish Singhal. He's a senior consultant, medical oncology in Indraprastha Apollo Hospital. He'll be taking us through BRCA mutations in pancreatic cancer. Over to you, Dr. Manish.
Yeah, once again. Yeah, am I audible?
Yes, sir.
Okay, thank you. My slides are visible?
So it's visible. Can you put it on slideshow?
Yeah, I'll do that.
Yes,
so I'll be dwelling on the importance of BRCA mutation testing in pancreatic cancer and what is the data that we have about the incidence of this particular mutation. And of course, after that, there will be a subsequent talk on the role of and the Polo study, which was an NEGM publication, which changed and included olaparib as one of the treatment options in maintenance after therapy for advanced pancreatic cancer. So I think this has already been dwelled upon, and we know that pancreatic cancer is fairly common, accounts for about 2.5% of total tumors that we see, and it ranks in the top 10 cancers that is seen by a medical oncologist or oncologist for that. And it's fairly one of the leading causes of cancer mortality. And so, because most of these cancers are detected in late stages and are largely incurable, even if detected early, the median overall survival range is between 20 3 months, 25 months to around 50 months, with perhaps follicular showing the highest survivability in that case. As far as the prevalence of homologous recombination related gene mutations across multiple cancer types are concerned, and if you look at the middle of this bar graph, we see that breast and pancreas is almost the same, with the incidence of BRCA mutation being different between the two tumors. But as far as homologous recombination related gene mutations are concerned, the incidence seems to be around 15% in both breast and pancreas. So it's very important to understand that pancreas is also one of the tumors where homologous recombination deficiency may exist in about 15 to 20% patients, and that is something which is druggable and it is targeted. So this 15% mutations, mostly the most common of these mutations, the prevalence is with BRCA2 mutations followed by BRCA1. Another mutation which are responsible for DNA repair mechanism effects are the MSH2, the PALB2, and the MLH1, and various such mutations which are responsible for homologous recombination. So, in one of the studies where 15% of these mutations occurred in the DNA repair gene mechanisms, included the most common ones were BRCA2, BRCA1. The other one were ATM mutations, and we know that ATM mutations may also be important from the profound study which randomized patients to olaparib in prostate cancer, where ATM was included in the cohort 1 for olaparib versus treatment of physician choice with either enzalutamide or abiraterone acetate, where ATM was one of the mutations which was tested. Other than that, uncommon mutations were also studied in the profound study for prostate. So this is also very important to know that these mutations may also be something which can be drugged and they're highly actionable. ARD-D1, DID1A, which is 5.5%, is also related to gene repair and DNA repair mechanism, but has other functions. So it's not purely a DNA repair mechanism effect. But we don't really know whether olaparib or any PARP inhibitor will work in this particular mutation carriers or not, because that is yet to be seen. So as far as the current status of PARP inhibitors are concerned, it is for BRCA mutation carriers and PALB2, and perhaps ATM also, but that was not really tested in the whole study. So BRCA1 and BRCA2 are proteins involved in the homologous recombination repair pathway, and we know that there are various forms of DNA damages which can happen, such as base alkylation, the DNA single strand breaks, double strand breaks, base mismatch insertions and deletions, and adducts. And there are different enzymes and proteins which are involved in repairing these. But what is more important is the DNA double strand break repair mechanism, which involves the BRCA1, BRCA2, the RAD51, the CHEK1 and 2, the ATM. So these are called as the homologous recombination repair system, which is important for the functioning of the PARP inhibitors. So we know that we also came to know from the various studies, such as the ovarian cancer studies, that not only germline recombination is important, but also somatic recombination is important. And there is a possibility that some patients may have somatic mutation and not really a germline mutation. But as of now, what we test for is the germline recombination as far as pancreatic cancer is concerned, and not really the somatic mutation. But it is quite possible that somatic mutation may also exist. As far as the prevalence is concerned, the prevalence is about 7%, and that is like 1 in 15 patients who have a germline BRCA mutation. Other than that, mutations such as the PALB2 and the ATM and the ARD1, where we don't really know whether the PARP inhibitors are there or not, but the incidence may increase as we come to know and we understand the other mutations well in respect to the PARP inhibitors. Between BRCA1 and BRCA2 is far more common than BRCA1. It is like 1:3, and we know that the mutations may exist more in some ethnic groups and people with family history of various cancers. So about 3 to 10% of pancreatic cancers may have about family history, and in that particular subgroup, the incidence of the BRCA1 and 2 mutation is far more than in randomly selected or unselected patients. And so therefore, the education point is that we need to test for everyone to look out for these particular mutations. So not really banking on the family history. The data does suggest that pancreatic cancer is more likely to develop in younger patients if they are germline BRCA mutation carriers. As such, they are generally younger than 50 years of age, and the median age is much lesser for germline BRCA mutation carriers as compared to random patients. So the cancer seems to occur better here. As far as the prognostic value is concerned, so there are different data. Uh, One say that there may be an improvement in survival. Perhaps these patients were exposed to platinum-based therapies. That is the reason. And in the other study, there was an inferior survival with BRCA mutation. So nothing is very clear on whether BRCA mutation status carries a poorer prognosis or a better prognosis in patients of pancreatic. In the Polo study, there were around more than 2,000 odd patients. There were around 3,315 patients who were screened. About 7.2% came out to be BRCA mutation positive, and 6% of them were actually newly identified patients. And the highest prevalence was in the US, Israel, and France population. Other than that, there were other populations which were included, about 85 patients which were positive, other than the country of origin. Also, it is seen that patients who have BRCA mutation status and have pancreatic cancer, their outcomes are far better if they are exposed to platinum-based therapies. And this is for locally advanced in stage 4 patients. And one can see that for non-platinum based, it is less than a year, but it is definitely in excess of 1 year if they are exposed to platinum-based therapies. As a matter of fact, in one data set, it was around 2.37 years if they were exposed to platinum-based therapies. And this is quite akin to what we understand from breast cancer and ovarian cancer. Also, the NCCN guidelines do recommend BRCA mutation testing not only for the use of PARP inhibitors, but also changing therapy options from gemcitabine nab-paclitaxel, which is by far the most favored protocol and most easily tolerated protocol, to changing it to gem plus cisplatin-based protocol if you are a BRCA mutation carrier, be it be a locally advanced or metastatic setting, or a FOLFIRINOX or a modified FOLFIRINOX. So there is therapy selection because one would want such patients to be exposed to platinum to get the survival benefit rather than that. And so this is about the generalized the NCCN guideline workup. It does necessitate that whenever you have a confirmed diagnosis of pancreatic cancer, germline testing should be done. And even in metastatic setting, one may opt for olaparib maintenance after 4 to 6 cycles of 6 months of chemotherapy in a patient who has got a good performance status. One can use olaparib as a maintenance therapy. That is exactly how it was done in the Polo study. It was used as a maintenance strategy and not as a treatment after progression, but as a maintenance strategy where it improved the progression-free survival. And so this is what the NCCN guidelines talk about, that if the patient is a BRCA1, 2 or PALB2 mutation carrier, you may choose between FOLFIRINOX or gemcitabine cisplatin and see if the patient can receive chemoradiation in case it is a locally advanced disease, or you can use olaparib as a maintenance therapy in patients who have BRCA1 and 2 mutation after chemo. So that I thank you for your kind attention and over to the organizers.
Thank you, Dr. Manish. Quickly, before going into the next session, I think Dr. Sham just asks a question that are these mutation in tumor somatic or germline? Dr. Sham, if you want to ask directly to Dr. Manish. Or
it is germline, sir. So far it is germline, but I would not hesitate in using a PARP inhibitor in case it is somatic mutation. But as far as the data goes, it is germline mutation.
Correct. Thank you, Manish.
Yeah.
Thank you, sir. Thank you so much. So moving on to our next session, we have Dr. Vineet Talwar. He is the Director of Department of Medical Oncology in Rajiv Gandhi Cancer Institute. And today he'll be talking PARP inhibitors in metastatic pancreatic cancer. So over to you, sir.
Good evening, and I thank the organizers for giving me this opportunity to discuss something which is very new and enlivened CA pancreas, so as to say, which was going towards dormancy with a very abysmal progression-free survival rates, especially in the metastatic setting, which Dr. Shyam also alluded in the initial lecture. So, coming to the study, this was the Polo trial. Next slide, please. So, this, as you see, this was in metastatic pancreatic cancers who had a germline BRCA mutation with a good performance status, and they had to have at least 4 months of treatment. That is about 16 weeks of treatment with the platinum-based chemotherapy. And following that, it was a 3:2 randomization in which 92 patients out of 154 were given olaparib 300 milligram BID versus placebo, which is 62. And this was treatment going on till progression. But the primary endpoint in this was progression-free survival, and however, the secondary endpoints were the overall survival at specified cutoff time, with the second progression-free survival, which was very, very important. And of course, the toxicity profile and the quality of life issues. Next slide, please. So this trial was globally studied, which enrolled patients from 12 countries worldwide. So you had about 154 patients, and predominantly from the US, France, Israel, and Germany. Next slide, please. And it was found that in these patients, 7.5% patients had germline BRCA mutations. And the thing to note was in this study, there was no crossover from placebo, which was allowed. Next slide, please. So the baseline characteristics were well matched between both the arms, whether it was more than 65 years or less than 65 years, as you can see. And predominantly they were male patients, and most of these patients had BRCA2 mutations that accounted for about 70%, 30% had BRCA1 mutations, and all of these patients were in good ECOG performance status. The median months of treatment prior to olaparib was about 5 months in the placebo arm as well as the olaparib arm. Next slide, please. The common site of metastasis, which we see prior to chemotherapy in both treatment groups, was liver. This was followed by lung and peritoneum. And stenting was done in one of these patients. Next slide, please. All these patients, as you can see, they were well balanced in terms of their response to first-line chemotherapy, whether it was FOLFIRINOX or its variants, or gemcitabine and cisplatin. And the types of previous chemotherapies predominantly were triplets, meaning thereby most of these patients had received FOLFIRINOX as the standard of treatment for the 4 months prior to enrollment in this, and about 15% were the ones who had taken doublets. The median time from diagnosis to randomization was about 6.9 or 7 months in both the arms. And the best response on the first line treatment would be stable disease in 45 patients and a PRC in another 46 patients. And it was naturally less in the placebo arm. Next slide, please. So here you had significant improvement in the progression-free survival, reducing the risk of progression of death by 47% compared with placebo. So if you see the median progression-free survival, which was the main aim of the study, this was 7.4 months vis-a-vis 3.8 months. So median difference of about 3.5 months. And this also you can see the time from randomization. The curves they split very quickly, which was very stark. So it was double as compared to the placebo which was there. Next slide, please. So as much as you can see twice the patients were progression-free survival following olaparib treatment compared to placebo at all time points assessed, whether it was 6 months or 12 months or 18 months or 2 years. So the people or the patients who were free from progression or death at 24 months, it was just the double as compared to placebo. This is about 22.1 months. And next slide, please. As I had already told you earlier, majority of the patients, that is about 2/3 of the patients, had received FOLFIRINOX or its variant that was modified FOLFIRINOX for at least 4 months prior to the randomization in the study. And the thing which was heartening was that whether the patient had a partial response or a stable disease prior to the randomization or prior to giving olaparib, it had no bearing on the olaparib response. So that means the olaparib response was agnostic to whether the patient had a stable disease or had a better response in these patients. So this was very heartening to see from this study. Next slide, please. And the progression-free survival benefit was consistent. I told you, irrespective of the PR or SD, it was consistent across the pre-specified patient groups, whether it was FOLFIRINOX or variants, whether it was doublets or triplets, whether it was treatment before randomization 4 months or greater than 6 months, or whether it was the response rates. So you find that you see this forest plot, it goes towards the olaparib arm vis-a-vis the placebo. Although one thing is there that Polo was not powered to demonstrate difference between such subgroups. Next slide, please. So about 23% of patients with measurable disease at baseline had a response to olaparib treatment. And you find that 2 patients, which is very surprising, 2 patients had a complete response, which was very good, which was never seen earlier in any one of those trials. And if you see the illustrative summary of first-line treatment, next slide, please, you would find that if you see the time on first-line chemotherapy, the median was about 5 months or 6 months. Even if you take modified FOLFIRINOX, the best times are about 6.4 months. And if you take only 5FU, it is just 1 month. So you have a range of 1 month, that is 5FU only, versus gemcitabine, which is roughly about 3.5 months, to a max of 6.4 months, which was PFS. So when we gave the maintenance olaparib in these patients, you find that there is a quantum leap of 5 months plus 7.4 months. So you cross the 1 year mark very, very easily. And the second PFS is about 13 or 13.2 months in olaparib arm. Next slide, please. So this was what I was alluding to in the last slide, that there is a significant unmet need to prolong the disease control as a part of the first-line treatment for patients with pancreatic cancer. And as you can see, if you give single agent versus a triplet, there is a difference of 1 month versus 6.4 months. But then again, there is a lot of room for improvement, and which I told you that if you add the PFS, the second PFS benefit, which olaparib gave, about 7 to 7.4 months, you have crossed 1 year and you have reached about 13 to 14 months. Next slide, please. So to summarize these endpoints, you have the first PFS about 7.4, second PFS about 13.2, survival at one point, if you check, it is about 18.9 versus 18.1, although this was not the primary endpoint of this study. And the p-value is also not significant in this case. Probably later on we will come to know about it. And if you see the consistency of olaparib, next slide please, you find that, as I told you earlier, the PFS2 has jumped up from 9.2 months, that is in placebo, versus 13.2 months. And at 2 years, almost the double number of patients are alive, that is 22.1% versus 9.2 months, the percent. So definitely, if a patient has this BRCA mutation, whether it is BRCA1 or 2, these are the ones who are definitely going to benefit if this is given as a maintenance. Next slide, please. So when you give this drug, you have the adverse events. So generally, adverse events were mild to moderate in the olaparib arm. We have used this in some patients of ours, and fortunately, till date, have not encountered serious adverse events. So the grade 3 events, grade 3 or higher, they were seen in about 40% of patients in olaparib vis-a-vis placebo. And any adverse event which was leading to discontinuation of treatment was seen in about 5% of cases. Next slide, please. So if you see broadly the side effects which are there, the common were the GI side effects. There were nausea, fatigue, and anemia. And out of this, fatigue was the commonest, followed by nausea, followed by the others, that is diarrhea, anemia, and abdominal pain. So it was a very well tolerated drug because these could be very easily controlled. Next slide, please. And as I told you, only fatigue resulted in treatment discontinuation of more than one patient. So about 2 patients were the ones who were discontinued because of fatigue. And the others had arthralgias and myalgias, which can happen with these drugs. So the adverse events which have been, next slide please, of special interest, especially in olaparib, which has been alluded to in other organs like ovary, etc. There has been a lot of concern about MDS or AML in these patients because of the pathway of the drug, and also secondary malignancies and pneumonitis. So this study did not show any events which were related to MDS or AML or any new primary malignancies which were there. There was one event of rectal cancer in the placebo arm and one potential event of ovarian cancer. Both were in the placebo arms, so they were not related to the drug per se. Pneumonitis was seen in one non-serious event as a non-serious event in the olaparib arm, but again, MDS, as it was seen in about 1 to 2% of cases in other studies in other organs, this was not seen in the Polo trial, which was done for pancreatic cancer. Next slide, please. After the adverse events, we come to the quality of life analysis, which was again a subgroup analysis, secondary endpoint in this study. And as you can see, not much difference in the HR QOLs in these patients. The estimated difference was about minus 2.47, meaning thereby that as compared to the placebo, the quality of life issues were not very many in this trial. Next slide, please. So to summarize, to conclude, the Polo regimen establishes a new paradigm for biomarker-driven approach to treatment in pancreatic cancer. And maintenance following platinum therapy significantly improves the PFS in patients with germline BRCA-mutated metastatic pancreatic cancers compared with placebo. And the PFS, as I've shown you, is practically double as compared to the placebo. And even at 2 years, about 20% of patients were progression free as compared to 10% which was there in the placebo arm. And 1/5 of all patients had a response while on olaparib maintenance, the majority of which were durable with a median duration of response of over 2 years. So overall survival and PFS2 are not mature, which Dr. Amish is asking. I think definitely if the PFS is double, then we are looking at significant OS benefit in times to come, because at 2 years we cannot say much. And of course, there is a concern about quality of life issues in most of these new drugs, but this drug, as of now, as you can see in the study, was very well tolerated, with just fatigue and anemia as the commonest adverse events which were there. And fatigue was the one which led to discontinuation in only 2 patients in the study. So I think I will stop there. I thank you for the patient hearing. Back to the organizers.
Thank you so much, sir, for your wonderful talk. Now, moving on to our panel discussion, we have the moderator with us, Dr. Ankur Bahl. He's the senior consultant, Max Super Specialty Hospital in Medical Oncology. So, over to you.
Thank you, Shilpa. Shilpa, can you hear me? Can you?
Yes, sir. We can hear you as well as see you as well.
Slide. And all due regards to the panelists and colleagues, and thank you, Astra, for giving me this chance. So may I? My panelists are Dr. Sumit Goyal from Rajiv Gandhi. Is Dr. Sumit here? I can't see him. Dr. S.P. Kataria from Safdarjung Hospital. Dr. Kataria, I can see him. And Dr. Amit Gora from Hope Center. Amit, are you there? Dr. Rajat Saha, I can see Dr. Rajat from Max Parpakam, and I can see Dr. Mustafa Ahmed. So if everybody is around, Dr. Amish, can you hear me?
Yes, I can hear you.
Thank you.
Yes, I can hear you.
So as we have heard Dr. Bhavna Siroi regarding metastatic pancreatic cancer, what are the options we have for the GEM the chain capecitabine in adjuvant then we've heard Dr. Manish Singhal regarding the importance of BRCA and how BRCA, the mechanism of action and those they were illustratively dissected the trial and made understand very quickly how very rightly said that should give us OS benefit as we see in the trend in ovarian cancer as well as in breast cancer. But if it doesn't give us OS benefit, then it will be always questioned as whether
Ankur, you are not that audible. Can you come near the voice is breaking?
Can you hear me now?
There is a lot of static, but not necessarily from Ankur's side.
Shilpa, can you stop my video if possible? Your end. Okay. So
mute first, then we may hear it.
Lot of disturbance some back end. Okay, it's better. Can you hear me now?
Yes, sir.
Much better.
Yeah. So as I was saying, Dr. Vineet clearly said that there's a PFS benefit and the PFS2, PFS1 was around 13-14 months. So that should give us OS benefit. And if it does not turn up as a OS benefit, then the Polo trial will be questioned as is whether this 3.4-month extra PFS as compared to there was a study of there are many studies, phase 2 studies of maintenance chemotherapy agents as well, which we are practicing prior to olaparib. So let's discuss this, and let's start with our panel discussion. So Dr. Kataria sir, so what do you think, as these slides have been shared before, what is your experience on pancreatic cancer, the deadliest cancer, and why we have not able to break through, why our OS is too low, survival rates are too low? Dr. Kataria sir.
Yeah, most of the patients that we get are either locally advanced and totally unresectable or metastatic.
Yeah.
Well, the kind of patients that we get are not really the good performance status. Generally, the prognosis is very poor.
So, but Dr. Kataria, as we see other cancers, gastric cancer, they are also present in an advanced and metastatic center. But what is the reason, Dr. Amish? Can you answer this? What is the reason that pancreatic cancer has not shown that much response rate and that much survival benefit? Any technical reason which you can figure it out, Rameshwara?
There is a lot of studies being done about the biology of pancreatic cancer, and especially stromal factors and hyaluronidase factor have been studied. Olaparib is one different mechanism, but what I think is, if you see the protein study in an adjuvant setting, FOLFIRINOX versus gemcitabine, there is a huge difference. So this is somewhere like in a press where CMF era was there. So I personally think is that we have still not understood the biology. 7% of the patients have BRCA1, BRCA2, and 12% of the patients have homologous repair gene. But we are forgetting that 90% patients have KRAS mutation. If we can identify a particular mechanism by which we can circumvent this KRAS mutation and its downstream pathway, I think we'll make a majority of the dent there. Till that time, we'll have to rely on chemotherapy.
Yeah. So you rightly said about the stroma. So what is it? It is called is, I still remember my training days, that it's a desmoplastic reaction which is very prominent in this pancreatic cancer, and it is the marked proliferation of this actin fiber like of thing and the lots of extracellular matrix. So the penetration of chemotherapeutic agent is not that much as we see in other cancers. So that is the reason that the gemcitabine study, the 5FU study, and the nab-paclitaxel gemcitabine. So it was a lot of hype about the spark protein, which the Biocon company claimed at that time that Abraxane is actually a targeted therapy because it targets the spark protein in pancreatic cancer, but eventually it did not give us that benefit which other cancers or in which another organs have been studied, and that's why the response rate in pancreatic cancer was pretty much less as compared to the other solid organ cancer. So Dr. Mudassir, your practice, you have seen lots of other cancers. So what do you see in last decade or so, 5 years or so? The clock has not moved in pancreatic cancer. However, it has moved in lung, ovarian, kidney. If we don't discuss the Polo trial, there is not much of achievement which we see in pancreatic cancer. Dr. Mudassir. So I think
I have not, sir, heard about how much of research is going on in the pancreatic cancer per se. Probably because some of the cancers like the lung cancers, breast cancers, myeloma, they had a lot of research research money put in from so many years, and that's why we are seeing a lot of development. I don't know. Probably that much of research allocation may not have been done in the pancreatic cancer, and that's why we are not having the target therapies in this. And now I think with this PARP inhibitor thing, maybe we see such a similar development in this, and probably some big guns are having the pancreatic cancer. That sometimes it diverts a lot of research money into study of cancers.
That's a very valid answer. I mean, the kind of research, the kind of money put in, maybe this cancer does not give us that much time in which the practice or in which the research can happen. Maybe the immunotherapy era which is coming us can put light on what is the MSI rate, what are those NGS marker, what are those somatic. So I'll discuss a study from Memorial Sloan which have said that actually the actionable targetable mutation in pancreatic cancer is as high as 45%. So yes, you're right. Maybe the research has not happened in that way, that in another cancer, and Dr. Shyam Agarwal clearly opened his remark that it's an unusual discussion as well in pancreatic cancer. We have a lot of discussion in lung, breast, and all. So pancreatic cancer is probably untouched or less touch as compared to other cancers. So this slide again have been discussed. So we have seen the era of 5-AFU, gemcitabine, erlotinib, gem nab-paclitaxel, and then the folfirinox giving us 6.4 months benefit as compared to the 5-AFU or 3. But there was hardly any randomized trial comparing each with another one. So ultimately this disease turned out to be a tough disease, and in last decades or 15 years of pancreatic cancer. So this POLO trial, which targets the BRCA mutation, actually gives us some ray of light or hope that this drug, if mutated, if this mutation is being targeted, maybe in 7% of the cases, 5% of the cases, we can identify and pick those patients who have this biomarker. So again, repetition. So now in the era of 2019-20, we have olaparib, we rely heavily on NGS, we rely heavily on MSI status. If high and if there is mismatch repair gene pathway, so we can target these actionable mutation or through IOs through this MSI, and we can have this maybe PFS benefit. So Dr. Rajat, so the factors deciding in pancreatic cancer, when it comes to the ground level, what all decides the outcome of this pancreatic cancer in your practice, Dr. Rajat Saha?
Basically, it is first of all the stage at presentation. Most of the pancreatic cancers are presenting at stage 4. Second bad feature about it is the obstructive jaundice. The presence of obstructive jaundice is a very poor prognostic marker. Presence of associated comorbidities like diabetes is there. So that also hampers, and as Dr. Bhavna also told, that the performance status, the initial performance status of the patient is very much predictive of the overall outcome. And all these pancreatic cancer patients, even though pancreatic cancer is considered to be a disease of the first world countries, but still once the pancreatic cancer sets in, the patient is highly nutritionally debilitated. That also hampers our treatment. So performance status, stage at presentation, presence absence of obstructive jaundice, and comorbidity. So these are the additional factors.
Dr. Amish, would you like to illustrate on any of this or any other comments what decides pancreatic cancer? Dr. Amishwara.
I think he has said, Rajat has said almost everything, Ankur. As we go forward, maybe we can have more discussion.
Okay, great. So yes, the BRCA mutation, as Manish discussed in his slides, that the BRCA mutation status, whether it is a good prognostic or a bad prognostic, so there are unclear. I mean, it's still debatable. So there are a couple of studies which says that the BRCA associated pancreatic adenocarcinoma. One of the studies says that they do well, and another study says that they don't do well. So it's a divided house whether BRCA can be a predictive prognostic marker. Yes, it is a predictive marker. It responds to platinum-based therapy, but whether it is a prognostic marker or not, it has to be decided again. So according to
Ankur, can I say something here?
Sure.
Yeah, so BRCA and predictive or prognostic, see, depend, before gemcitabine and nab-paclitaxel, we always used to give gemcis.
Yes.
So I feel in the studies where gem nab-paclitaxel is first used, probably the BRCA mutation will do bad compared to those who have used gemcis or folfirinox. That is how we can look at it.
Yes. So that brings another question. So I want both Dr. Mudassir and Dr. Kataria sir to answer. So NCCN recommends that all pancreatic adenocarcinoma germline testing should be recommended, and I believe all my panelists agrees with that. And if there is a disagreement, my panel can again say. So all of you do BRCA testing upfront when the diagnosis of metastatic breast cancer has been done. We can start with everybody. Dr. Amish, Kataria sir, and Mudassir and Rajat. We all do BRCA testing upfront, or you decide which patient to go BRCA testing or which patient not to go BRCA testing.
We counsel all the patients. Sorry, Ankur, let others speak. Sorry.
Yeah, no, Amish, continue.
We can start one by one.
Okay. Ankur, so I will start. Amish here. We like to do in all. I counsel all the patients in locally advanced, unresectable, and metastatic pancreatic cancer to go for germline BRCA. But the question comes is that if there is a clear-cut patient that who cannot afford olaparib, just for the sake of gemcitabine, cisplatin, or FOLFIRINOX, should we do germline BRCA mutation? Is a question in a day-to-day clinic comes. But yes, I counsel almost every patient of mine for germline BRCA mutation, if that's a question.
Yeah. Dr. Rajat, you were saying something.
Yeah, I also agree that in the last few months, we have graduated to doing BRCA testing in our patient. Even though we haven't come across a great deal of only one patient out of maybe 7 or 8 were positive. So again, it comes back to the same status, about 4 or 5% are positive. So yes, we should do. When we have some actionable thing amongst nothing, we should do it.
So I, Dr. Mudassir and Dr. Kataria, one comment from you each, if you are there.
Sir, my take on this is, sir, we should be doing in all the patients. I think should be doing in all the patients. There are 3 reasons to do it. One reason is, as everybody said, that one reason is that we may decide the chemotherapy, or we may later on change the chemotherapy to a platinum-containing agent. Number two is we may offer the patient olaparib. Number 3 is it will help us in family counseling also, genetic counseling also. I think there are 3 advantages. Genetic counseling probably should be done in all of the patients, even if they will not be able to afford olaparib. So I think it should be done in all the patients. I have a question actually. About 5 or 7% may be having germline. About another 5% or so may be having somatic. And if we test the somatic, that means the tumor tissue, it will contain somatic as well as the germline mutations. So if we tend to use this, olaparib maintenance in all of those patients, whether they are somatic or germline, should we be testing on the tumor tissue rather than on the blood?
Yeah. So that's my next question to my panelists. I am the moderator, and you have to answer this question again back. So these cancers are bad cancers, and many times we land up with the patient who want to do everything on them, every garden, every foundation, every caras. So Dr. Ameshwara, so any other biomarker, patient wants everything for him, any other biomarker except BRCA1, BRCA2, would you like to go for a comprehensive gene assessment and next generation sequencing? Do you do MSI, MMR later on or upfront? And again, a next question, as we do in ovarian cancer, we have a HRD score from Mared. Do we rely on these HRD score because there are BRCA-like mutation, which the DNA repair mechanism can be hampered by other mutation, the PAL-B2 mutation and the other ATM check mutation. So do we go that way in pancreatic cancer? If a patient of a lung cancer, yes, we are very aggressive, but what about pancreatic cancer? Dr. Ameshwara.
Yes, so Ankur, you have answered half, and my answer is yes. In a metastatic patient, before starting the first-line chemotherapy, I counsel patients for germline as well as NGS both. The reason NGS is because, as we have learned from ovarian cancer, we need tissue. And as Mudassir said, we need tissue for homologous repair gene deficiency to be addressed. I have had one patient who's PALB2 and one patient who had ATM. At that time, I did not know whether ATM and olaparib will work, but in PALB2 patients, I had started olaparib as a second line treatment, means after as a maintenance treatment. So to answer your question, yes, if the patient, and even NCCN guideline says that in a locally advanced and metastatic disease, apart from germline mutation, the genetic profiling of all the patients should be done. In fact, one patient which me and Dr. Ved commonly shares, one was 100% positive. Locally advanced disease unresectable. What do you do? But so, as we go, get to know about these things.
So very rightly said. And I remember at one point of time, Astra people came to me, and I gave them this idea that why not pick up those tissue blocks, and Astra should fund on the somatic BRCA mutation testing, and then we can look retrospectively what is the incidence of somatic mutation testing of BRCA. Let's forget everybody, and how many of them responded to platinum. I think that could be a research question. And since we have pancreatic cancer, I won't say it's a rare cancer, it's pretty common cancer in practice, and this research question can be solved if we do a somatic mutation testing. And this is a Memorial Sloan Cancer Center paper which was published in Clinical Cancer Research. So
Ankur,
not
Ankur?
Sir?
Dr. Sham this side.
Sir.
So, I had put this question, the timing of the BRCA testing in patients with metastatic pancreatic cancer. So, if you do it upfront, before starting any chemo, and you find BRCA1 to be mutated,
yes.
So, do you prefer using a platinum instead of, nab-paclitaxel?
Yes, sir. So it's sir. The first line of agent, if patient is fit, the performance status is good, I am inclined towards FOLFIRINOX. So that gives me a 3-drug regime. So it all depends.
I understand. No. But then if you, in the absence of BRCA1, 2, well, I'm not very keen on pushing FOLFIRINOX because I'm fairly happy with a milder kind of a protocol with nab-pacli. So should it not be, prudent on our part to do PRCA1, 2 upfront to choose between the two protocols?
Yes, sir. I mean that is again a study setting, that BRCA mutation upfront, and there is a data in literature. Let me see that. Yeah, there is a data in the literature. Those BRCA mutation positive patient responds to platinum more, and I think we should be tempted, as we do in triple negative breast cancer. If that's a very good idea, that BRCA mutation upfront, the report comes in 2 weeks time. If the BRCA mutation, BRCA2 or BRCA1 is positive, we should be tempted towards using GEMOX or GEM platinum, GEM cis, or maybe even FOLFIRINOX if the patient.
I think Manish had shown some kind of an algorithm for deciding on the chemotherapy based on the BRCA status to be done upfront. So I think
this graph shows that DDR deficiency, the repair mechanism deficiency, predicts overall survival improvement in platinum-treated pancreatic adenocarcinoma. And your question is absolutely right. If there is a BRCA2 mutation positive, platinum should be added. But if it is negative, then we should be very happy with gemcitabine and nab-paclitaxel protocol.
So that should be a practice-changing, for clinicians like us.
So NCCN guidelines, sir, it says that the moment you have pancreatic adenocarcinoma word, you should do germline BRCA mutation. That is what it says.
So currently, in my practice, I am not doing it upfront. So I do it after the failure of the first line chemo. So what I'm trying to say is that we should change that practice. I mean, I'm willing to change my practice based on.
No, sir, we all are doing that. Yes, sir, we should take that. The reason is that even in an adjuvant thing, FOLFIRINOX for overall was better than gemcitabine, but still in poor performance status, we still use gemcitabine in adjuvant setting. But assuming if the patient is BRCA positive, would you add cisplatin to gemcitabine, or would you change to FOLFIRINOX? Is a question.
The answer is clear there. That if you have used gemcitabine and the patient is relapsing within, say, 6 months or 9 months or so, and BRCA positivity, we would not like to use gem again. It would be FOLFIRINOX.
No, sir. I'm saying post-surgery, if the BRCA is positive, you have still not started adjuvant treatment, and if BRCA turns out to be positive, patients between folfirinox and gemcitabine, the patient is fit for folfirinox. Would you give only gemcitabine or would you add cisplatin in an adjuvant setting?
I know, I understand. So it's the same story of using platinum in triple negative in the adjuvant setting. There is no consensus. Same story.
Correct, sir.
Okay. So there is no data at the moment.
Agarwal, you said that you will be doing BRCA mutation on progressive disease, but POLO trial inclusion criteria was those patients who have responded to the first line, and 80% of the patient actually got folfirinox. So POLO trial was those patients who are responsive to chemotherapy. Then they were randomized into 3:2 fashion between olaparib and placebo. So as Amish rightly said, that we should get BRCA upfront and then use it in the responsive setting when they have responded to our chemotherapy, rather than waiting for the progression and then using olaparib as a therapeutic way. Yes, there are studies with rucaparib and all, which they have shown responses in phase 2 study. That's my last slide. But yes, POLO trial used when whosoever patient was responsive, then only olaparib was added as a maintenance. So BRCA mutation should be tested upfront as per NCCN, and as Dr. Amish already said. So Shilpa, I'm running 10 minutes late. Is it okay? Shall I start or you want me to wrap up?
Ankur, can I ask you to ask a question? Since you are the moderator, you have to ask this question to all panelists.
Okay. Hello? Shall we write Amish, tell me.
No, so if BRCA positive and PD-L1 also positive, I want to know in a second line setting, not in the first line, would any of the panelists or audience give olaparib along with immunotherapy?
Where is the evidence?
There's no evidence, sir.
So no, don't give it. It's only for MSI high. So
yeah, MSI high. This was the study. There was two studies, study 42 and the rucapanc study, in which olaparib monotherapy and rucaparib monotherapy was given to BRCA mutation advanced pancreatic cancer, and these two studies have already received 2 lines of setting. So it was a progressive setting, and olaparib and rucaparib was given as a therapeutic option, not as a maintenance option, and there was an overall response rate of around 21% in the study 42, which was an olaparib study, and 15.8% in the rucaparib study. So there are phase 2 studies going on, and many more also, which says that therapeutic PARP inhibitors can also be tried if there's a progressive disease, but yes, response rates are in the tune of 15 to 20%. So I'll just rush through a case, and which will be like 53-year-old patient who was August 2016 pancreatic adenocarcinoma, stage 4 liver metastasis, good performance status except hypertension, CA 19.9 high, BRCA2 185 deletion, germline carrier, took folfirinox. He was a good performance status, and grade 2 neuropathy after folfirinox. This is the So he was given folfirinox. So as my panelist and all panelists must have agreed that, except Dr. Agarwal, who is not fond of folfirinox, he was 53 good performance status except hypertension and episode of TIA. So in this patient, we have plenty of options: gemcitabine, NAP, paclitaxel, gemcitabine, platinum, or a triple drug folfirinox. This patient was given folfirinox. I just want to emphasize on this slide, whether this is in your mind or not. If you have not given folfirinox upfront to a patient, worrying about his performance status and worrying that he might land up into a febrile neutropenia or he may not tolerate. So is folfirinox a second line option ever if you have not given upfront? Dr. Shyam Agarwal, sir.
Yeah, absolutely. If the patient remains fit after the use of gem and paclitaxel, sure.
Why you use upfront then? In that case, he must have been fit.
No, you see, these patients, whatever my experience is, one thing is that there's no data to support one over the other. Yeah. That's number one. The second is, a lot of these patients have icterus and they have these stenting done. The bilirubins are not like up to the normal levels, hovering between 2, 3. So folfirinox still remains a toxic treatment to my mind. And but then I think with this discussion going on, so I'm willing to adopt the use of platinum, whether it is platinum gem or folfirinox, in patients who are upfront found to be BRCA mutated. So that is the change in my practice from tomorrow. because the test is so very easy to perform, and the reports are available within 2 weeks time. So this basically gives me an impetus to use a platinum in BRCA mutated patients upfront. So which I've not been doing. I've been doing in all patients in the second line. But with this discussion on, I'm going to change my practice from tomorrow.
Yes. So as we talk about sequential treatment in colon, sequential treatment in gastric cancer. So yes, there is Gem-Nab paclitaxel followed by FOLFIRINOX 14.5, FOLFIRINOX followed by Gem-Nab paclitaxel 18 months, and then came the Prodage, which Dr. Bhavna Suri also discussed, the maintenance 5-FU and leucovorin. So this patient was given 8 cycles of FOLFIRINOX, grade 2 neuropathy. Then he was in 2016. He was enrolled in a POLO trial. Post FOLFIRINOX, there was a demonstration. There was a PR 13 November and 22nd March. There was a partial response in the disease, and 19.9 also dropped out. Then he was given olaparib maintenance after the response from FOLFIRINOX, and then he had a PFS of 9 months. So this is the RECIST criteria and the markers which came down and which came up in December. So 4 months of FOLFIRINOX, and then it gave to PFS 9 months on POLO. That's what Dr. Vineet Talwar was saying. So with BRCA2 mutation, this is a biomarker, and there's a remedy to this biomarker. We can have this survival beyond 1.3 to 1.8 months. So just quickly wrapping up another case, 74-year-old adenocarcinoma, liver metastasis, psoriatic arthritis, adenocarcinoma, again a germline carrier. Yes, 74 arthritis. So this patient was given gemcitabine and nab-paclitaxel, not the FOLFIRINOX, because of the age and the performance status. And this was the initial, we can see the celiac artery, SMA, and the liver metastasis. This is liver metastasis. So after gem-nab-paclitaxel and gemcitabine, there was a response, and August 15, this patient entered the POLO study, and CR since October 2015. This is a real case which has been taken from an international speaker. So 46 months complete response. So these are the ones, this is actually the targeted treatment. The responses which we might see from IOs and various other target ALK and EGFR in lung cancer. So this is the way the BRCA2 mutation have changed the scenario. It may change the scenario, and seeing this patient, we are waiting whether it can give an overall survival benefit or not. But but if you see the POLO design, the secondary endpoint, there were huge secondary endpoint: OS, PFS2, time to second treatment, time to secondary progression, TDT, time to study treatment discontinuation, overall response rate, disease control rate, quality of life, and safety, which Dr. Vineet Talwar has already said. I think I'm overshooting the time and coming on to the last slide. So POLO regime established a new paradigm for biomarker-driven approach to a pancreatic cancer, which it was lacking in last decade. The median PFS has improved 3.6 months. We are not happy with that, but yes, if it turns out to be an OS benefit, that would be a landmark thing. Global quality of life was similar to olaparib and placebo in this, and the safety profile. So we have been using olaparib in ovarian and couple of more prostate cancer as well. So fatigue is one of the commonest side effects which I see. Anemia is another one, and then we have to modify. There are charts to quantify anemia and to decrease the dose as per the anemia, 200 BD and 150 BD as per the study one, which was in ovarian cancer. So I think I thank all my panelists, and I thank Astra for giving this opportunity to discuss pancreatic cancer, and that to BRCA1 and BRCA2 mutated pancreatic cancer. It will open the Pandora box for pancreatic cancer in the near future. Over to Shilpa, please.
Thank you so much, Dr. Ankur. Thank you all the panelists from my side as well. It was a wonderful discussion. So I guess just to conclude, I'll ask Brigadier Dr. H.P. Singh. He's the HOD in the Medical Oncology Department, R&R Hospital, to give the concluding remarks. So over to you, sir.
Okay. Thank you, ma'am. Hello, good evening, colleagues and friends. Hello, Dr. Sham. It has been a very interesting evening today. First time a topic like pancreatic cancer is a topic for discussion. And I don't know whom to thank, but I must thank the organizers of the POLO trial, that it's back into the discussion among medical oncologist colleagues. Otherwise, we used to just say some FOLFIRINOX and that's it, and you go home. So I think after a prolonged night, this is first ray of hope, one ray of more hope, where we are making progress in pancreatic cancer. The TKIs with allotenibizin, pembrolizumab with MSI high is in. So now a combination of trials of these would start, and then let's see how it evolves, whether there would be a backbone of chemotherapies or further additions of more molecular targets. So we look forward future to more trials in pancreatic cancer so that we can improve on the dismal prognosis this cancer has. Thank you. I'm extremely impressed by all the speakers. They spoke so well and brought in good insight into this difficult cancer to treat. And thanks to all the audience who took out their valuable time, and thank the organizers for organizing this conference. Thank you very much.
Thank you so much, sir. And I thank all the speakers, the panelists, the audience.